Let us continue with the lab diagnosis of cholera. Specimen, watery stool or rectal swab for carriers, and transport media, VR medium or Cray-Blair medium. Direct microscopy, gram-negative rod, short curved comma-shaped fish in stream appearance. Hanging drop demonstrates darting motility. Culture, enrichment broth, alkaline peptone water, Monsieur taurocolate, telluride, peptone water. Selective media, bile salt agar, Monzius G triple T agar, TCBS agar, yellow colonies. McConkey agar produces translucent NLF colonies. Culture smear and motility testing reveals short, curved, gram-negative bacilli and darting motility. Identification: catalase and oxidase positive, ICUT indole positive, citrate positive or negative, urease negative, TSI amino acid upon acid gas negative, H2S negative. Strength test positive, it produces hemodigestion on blood agar. Automated systems such as Malditov and Vitek. Biotyping to differentiate classical and even TOR. Serotyping, serogrouping to differentiate between O1 and O139. Serotyping to differentiate between OGABA, INABA and Hikojima serotypes of serogroups O1. Antigen detection by cholera dipstick assay, molecular method, multiplex PCR detecting common diarrheal pathogens, antimicrobial susceptibility testing. Lab diagnosis. Specimens. Freshly collected watery stool is the specimen of choice for acute cases. Ideally, it should be collected before starting the antibiotics. Rectal swab is the preferred specimen for convalescent patient or carriers. Transport or holding media, specimen should be transported immediately to the laboratory if delay is expected. Stool 1 to 3 ml or rectal swabs may be inoculated in 10 to 20 ml of one of the following transport media: Venkatraman Ramakrishnan VR medium, alkaline salt transport medium, Cray-Blair medium. It is also useful for Salmonella and Shigella. Autoclaved seawater. Direct microscopy, gram staining of mucus flakes, feces reveals short, curved, comma-shaped gram-negative rods arranged in parallel rows, which is described by Koch as fish in stream appearance. Motility testing by hanging drop method, they are actively motile, frequently changing their direction, described as darting motility. Dart means a small, slender, pointed missile which shows sudden, rapid movement when thrown at a target. It is also described as shooting star or swarming gnats motility. Culture Vibrio cholera is strongly aerobic, non-fastidious, grows well on ordinary media such as nutrient agar. However, to inhibit the commensals, fecal specimen should be inoculated simultaneously onto enrichment broth and selective media. These media contain salt 0.5 to 1%, which stimulates its growth and have alkaline pH, which allows Vibrio cholerae to grow while inhibiting the fecal commensals. Enrichment broth, fecal specimen is inoculated onto enrichment broth, following which they are incubated for 4 to 6 hours. Thereafter, a subculture is made onto another selective medium as listed below. Prolonged incubation of broth should be avoided as the commensals may regrow. Alkaline peptone water can be used, or Monzius taurocolate telluride peptone water can be used. In this diagram, we see Vibrio cholerae gram staining, curved comma-shaped gram-negative rods, fish in stream appearance can be seen. Alright. Now the selective media. Stool specimen is directly inoculated onto a selective medium and the plate is incubated at 37 degrees Celsius for 24 hours. TCBS agar, it contains thiosulfate, citrate, bile salts as inhibitors, sucrose and has pH of 8.6. This is widely used at present. Vibrio cholerae can ferment sucrose and therefore produce large yellow colonies. Alkaline bile salt agar BSA. Vibrio cholerae produces translucent oil drop colonies. Monsieur's gelatin taurocolate trypticase telluride agar G/TTA. Vibrio cholerae produces translucent colonies with a grayish black center and turbid halo. Classical biotypes grow better on this medium than on TCBS agar. McConkey agar. When not sure about the type of enteric pathogen present in feces, McConkey agar can be included in the panel. Being a mildly selective medium, it also supports other enteric pathogens such as Shigella and Salmonella. Colonies of Vibrio cholerae are translucent and pale, which may become pink on prolonged incubation due to the late lactose fermentation. Culture smear and motility testing. Culture smear of the colonies reveals short, curved, gram-negative bacilli. Hanging drop shows typical darting motility. Identification is made either by automated systems such as Malditov or Vitek or by conventional biochemical test. The key biochemical properties include catalase and oxidase positive ICUT test shows the following reactions: indole test positive, citric test variable, urease test negative, TSI triple sugar iron test, being sucrose fermented showed acid upon acid gas absent, H2S absent. Hemodigestion on blood agar, this causes non-specific lysis of blood cells as seen as greenish clearing around the main inoculum. String test: when a colony of Vibrio is mixed with a drop of 0.5% sodium deoxycholate on a slide, the suspension loses its turbidity and becomes mucoid. When tried lifting the suspension with a loop, it forms a string. Biotyping: the classical even TOR biotypes can be differentiated by various biochemical tests: susceptibility to polymyxin B and bacteriophages. Serogrouping: species identification is always confirmed by agglutination test done on slide with Vibrio cholerae polyvalent O antisera. Specific serogroups can be identified using group-specific antisera. First, the colonies tested with O1 antisera. If found negative, then tested with O139 antisera. Serotyping: if agglutinated with O1 antisera, then the serotyping is done by testing simultaneously with Ogawa and Inaba antisera. If agglutinated with Ogawa antisera, it is designated as Ogawa serotype. If agglutinated with Inaba antisera, it is designated as Inaba serotype. If agglutinated with Ogawa and Inaba antisera, it is designated as Hikojima serotype. Antigen detection: at the point of care antigen detection test called cholera dipstick assay is commercially available. It is useful in the fields where laboratory facilities are unavailable. Now in this diagram we can see the Vibrio cholerae on blood agar, the hemodigestion is visible, and TCBS agar with yellow colored colonies of Vibrio cholerae, and the string test is also shown in the figure. Now coming to molecular methods. Molecular methods such as PCR can directly detect Vibrio cholerae specific genes in stool. Biofire film array is an automated multiplex PCR assay available commercially. Its gastrointestinal GI panel can simultaneously detect 22 different enteric pathogens directly from stool specimens including Vibrio cholerae. Antimicrobial susceptibility testing AST. As there is increasing trend of drug resistance in Vibrio cholerae, AST should be performed for guiding therapy. It is done on Muller-Hinton agar by disk diffusion test. Treatment: fluid replacement is the most important measure for management of cholera patient. It should be prompt and adequate to correct hypovolemia and thereafter to be maintained to replace the ongoing fluid loss. In mild to moderate fluid loss, oral rehydration solution should be given. In severe cases, intravenous fluid replacement with Ringer's lactate or normal saline should be carried out till the consciousness arrives, thereafter replaced by ORS. Antibiotics have minor role as the pathogenesis is mainly toxin mediated. Although not necessary for cure, use of antibiotics may decrease the duration and volume of fluid loss and hastens clearance of the organism from the stool, thus prevents the development of carrier stage. WHO recommends the use of antibiotics to only severely dehydrated patients, although wider use is not contraindicated. Drug of choice: macrolides such as azithromycin or erythromycin are the drugs of choice for adults, children and also in pregnancy. Alternatively, for adults, doxycycline and tetracycline or ciprofloxacin can be given in areas with confirmed susceptibility. Prevention: general measures include provision of safe water, improved sanitary disposal of feces, proper food sanitation, prompt outbreak investigation and taking necessary steps to reduce transmission. Notification: cholera is a notifiable disease locally and nationally, hence the cases should be notified. Infection control measures of contact precautions such as hand hygiene is crucial to limit the spread of the disease. Now chemoprophylaxis. Tetracycline is the drug of choice. Alternative drug include doxycycline. It is indicated to household contacts only during epidemic. Mass antibiotic prophylaxis may contribute to emergence of resistance. Hence, WHO does not recommend the antibiotic prophylaxis against cholera for travelers coming from or going to cholera endemic countries. Vaccine. Injectable killed vaccine, they are no longer in use as they provide little protection, cause adverse effects and fail to induce a local intestinal or mucosal immune response. Oral cholera vaccine (OCV) currently in practice. Two types of oral vaccines are available. First, killed whole cell vaccine. Whole cell WC vaccine is composed of killed whole cells of Vibrio cholerae O1 and O139 Two formulations are available: Shankol, India, and Uvicol, South Korea. Schedule 2 doses are given orally with minimum of 2 weeks gap for all individuals more than 1 year age. Protection and provides protection against cholera for 3 years. Whole cell recombinant B subunit vaccine WCRBS. In addition to composition of WC vaccine, it has recombinant cholera or toxin B subunit. Formulation it is available commercially as Ducoral. Schedule 2 doses are given orally with minimum of 1 week gap. The third dose is given for children and aged 2 to 5 years. It is given for all individuals more than 2-year age. Protection. It provides protection against cholera for 2 years. WHO recommends to use vaccine during epidemics and outbreaks in the community but not during the inter-epidemic period. Now the second one is oral live attenuated vaccine. They use mutant strains that lack the gene encoding for cholera toxin. CVD103HGR is commercially available as Vaxcora, given as single oral dose. Indication recommended for adults of age 18 to 64 years traveling to an area with active cholera transmission. It is also indicated to limit the spread of infection during an outbreak. Protection. It gives 90% protection at 10 days after vaccination, which lasts for 3 to 6 months. Non-O1 or O139 Vibrio cholerae. They may resemble biochemically to Vibrio cholerae O1 or O139 but do not agglutinate with O1 or O139 antisera. Clinically, they differ from O1 or O139 strains as follows. Gastroenteritis. Several outbreaks of gastroenteritis following seafood consumption have been reported from Mexico and other places. Stool is watery or partly deformed, less voluminous and bloody or mucoid. Many cases have abdominal cramps, nausea, vomiting and fever. However, they never cause epidemic cholera. Treatment is same as that of cholera. Fluid replacement is the most crucial step. Antibiotics can be given in severe dehydration. Extraintestinal manifestations such as otitis media, wound infection and bacteremia in patients with liver disease have been reported sporadically. Most of these infections are acquired by occupational or recreational exposure to seawater. Antibiotics are often indicated. Most strains are sensitive to tetracycline, ciprofloxacin, and third generation cephalosporins. So this completes your cholera. Now coming on to halophilic vibrio infections. The halophilic vibrios can withstand higher salt concentration more than 6% in contrast to Vibrio cholerae, which can tolerate up to 6%. They are widespread in marine environments. Cases tend to occur during late summer and early rainfall when the bacterial counts are highest in water. Vibrio parahemolyticus infections. Though Vibrio parahemolyticus was first reported from Japan in 1953, the incidence of infection has greatly increased in several countries including Japan since 1993. In India, it has been reported from Kolkata. Clinical manifestation. Foodborne gastroenteritis is the most common presentation, occurs following raw or uncooked seafood, example oyster intake. It commonly presents as watery diarrhea or rarely as dysentery with abdominal cramps. Extraintestinal manifestations such as wound infection, otitis, and sepsis are rare. Lab diagnosis. Lab diagnosis of Vibrio parahemolyticus is carried out similar to that followed by Vibrio cholerae. The distinct properties are as follows. Morphology. It is capsulated, shows bipolar staining in fresh isolates and pleomorphism in blood in older cultures. Motile by peritracheous flagellate, but it does not show darting motility. On TCBS agar, it produces green colored colonies, sucrose non-fermenter. Kanagawa phenomena. It causes beta hemolysis on Vagasuma agar, a special type of high salt blood agar. Swarming. It swarms on blood agar. Urease test is positive in few strains. Salt tolerance test. It can resist maximum of 8% NaCl. Identification can also be made by automated methods such as MALDI-TOF and Vitek. Now the treatment, most of the gastroenteritis is self-limiting and treatment is same as that of cholera. Indication of antibiotic use. Several gastroenteritis or extraintestinal manifestation associated with underlying disease such as diabetes, pre-existing liver disease, iron overload states and immunosuppression. Doxycycline or macrolide are the drug of choice. For proven bacteremia, doxycycline plus ceftriaxone is recommended. Now Vibrio vulnificus infections. Though rare, Vibrio vulnificus produces the most severe infection among the Vibrio species. Clinical manifestations can cause two distinct syndromes: primary sepsis and primary wound infection. Primary sepsis usually occurs in patients with underlying liver disease and iron overload or rarely in renal insufficiency and immunosuppression. Primarily, wound infection is characterized by painful erythematous swelling or cellulitis or even vesicular bullous or necrotic lesions. Generally affects people without underlying disease. Vulnificus is Latin word for wound maker. Lab diagnosis. Vibrio vulnificus can be cultured from blood or cutaneous lesions. It ferments lactose, which differentiates it from all other Vibrios. Identification can also be made by automated methods such as Malditov and Vitek. Vibrio vulnificus infections treatment, early antibiotic institution, wound debridement, and general supportive care are the keys to recovery. Vibrio vulnificus is sensitive to in vitro a number of antibiotics including tetracycline, fluoroquinolones, and third generation cephalosporins. Vibrio alginolyticus infection can occasionally cause eye, ear, and wound infection. Few cases of otitis externa, otitis media, and conjunctivitis have been reported. It rarely causes bacteremia in immunocompromised host. It's the most salt tolerant Vibrio and can grow at salt concentration of more than 10%. Identification can also be made by automated methods such as Malditov and Vitek. Disease is usually self-limiting. Severe infections respond well to antibiotics, tetracycline, and drainage. Now coming on to the Aeromonas infections. Aeromonas was earlier placed in the family Vibrionaceae. However, it has now been assigned a separate family Aeromonadaceae. Aeromonas hydrophila causes red leg disease in frog. Pathogenicity of Aeromonas in humans is mainly related to tissue adherence mediated by adhesions such as S layer and fimbriae. Capsular polysaccharide prevents the bacilli from phagocytosis. Exotoxins such as aerolysin, phospholipases, and hemolysins, enterotoxin and cytotoxin similar to Shiga toxin, and endotoxin or lipopolysaccharide. Clinical manifestation: over 85% of human infections are caused by Aeromonas hydrophila, Aeromonas caviae, and Aeromonas veroni. Most of the other species are mainly isolated from environmental sources and animals. Various manifestations include gastroenteritis, watery diarrhea, vomiting, fever, and rarely dysentery and peritonitis, musculoskeletal and wound infections, bacteremia in immunocompromised adults and infants, respiratory tract infections such as epiglottis, pharyngitis, and pneumonia. Lab diagnosis. Identification of Aeromonas up to the species level from colonies is made either by automated identification system such as Malditov and Vitek or by various conventional biochemical tests, example oxidase and catalase positive. Treatment of Aeromonas infection. Aeromonas is susceptible to ciprofloxacin and levofloxacin. Alternatively, clotrimazole and cefepime can be given. However, the plasmid mediated drug resistance has been reported, including beta lactamase production. Okay, so this completes our chapter. Now the questions. A 4-year-old boy developed severe watery diarrhea and vomiting. The stool collected has rice water type of appearance. Sent for bacteriological analysis. So clearly this is a case of cholera. The etiological agents, pathogenesis, and lab diagnosis can be done. A short notes on prophylaxis of cholera and halophilic vibrios can be done. Now coming on to the MCQs, which of the following media can be used as transport medium for vibrios? First, the Venkatraman Ramakrishnan medium. Second, which of the following tests can differentiate between even or biotypes of Vibrio cholerae except, okay, so which cannot differentiate this beta hemolysis on sheep blood agar can, chick erythrocyte agglutination can differentiate, growth on TC base agar no, because both show the growth, and polymyxin B also cannot differentiate, can differentiate. Okay. Now, pathogenesis of Vibrio cholerae involves one of the following second messenger systems. It's cyclic AMP. Now, selective media for Vibrio cholerae it's the TCBS. Okay, and coming on to which of the following Vibrio species halophilic except it's the Vibrio cholerae itself. Gardner and Venkatraman classification, which of the following is the biotype of Vibrio? The biotype of Vibrio is even tor. Okay. Now, O139 Bengal strain, all are true except it's the wrong fact is more common than even tor. Okay, because the even tor is more common these days. O139 is the older strain. Now, Vibrio cholerae, all are true except it is that it's acid level but stable to alkali, yes. Heat level, yes. And O blood group are affected more frequently, yes. The wrong statement is classical is more resistant than even tor. Is the opposite of it. All are selective media for Vibrio cholerae except, Alkaline salt agar, TCS agar, and Monsieur's agar can be used, but alkaline peptone water cannot be used. Now, last, which of the following confirms the isolate of Vibrio quality as Ecogema serotype? It is if agglutinated with both Ogawa and Inaba antisera. Okay, so this completes our cholera chapter. Next, we'll be starting with miscellaneous bacterial infection. Okay, thanks for watching. Like, share, subscribe.